Go to
the restroom earlier, maybe I shouldn't have, but nonetheless, we took a little more time, I guess, on this section than we should have. Okay? But nonetheless, y'all need to get this information because you want to be able to pass this test. All right? And a lot of this here is on this PowerPoint for you. And that's the reason that I wanted to use it in class, show you pictures and stuff. But there are certain things that you need to know. And we've kind of gone over some things up to this point, and I would like to just kind of review that with you for a second, if you will, up to this point, so we're all on the same page, okay? We talked about pressure ulcers to begin with, and that's pretty much a review from what you had in second level. And one of the main things, you know, we talked a lot about making sure that we give these folks adequate nutrition. We talked about how we need to position them so that we don't cause any more pressure ulcers, if you will. We talked about the importance of how we are to clean the skin at the time it's needed, rather than let them lay in something, and that's going to cause more skin breakdown. And also keeping these folks as mobile as we can, depending on whether we're turning them or walking them or whatever. We talked about unlicensed personnel being able to help us, and that they are not to assess, all right, or they're not to apply lotions to open places, or mess with lesions, in other words. Okay, they don't mess with that. We do as nurses, okay? And what they do is they bathe intact skin, right? That's what they can do. All right, so we're clear on that. And then we talked about the actinic keratosis. We talked about the different skin cancers and how we are going to instruct our patients on these assessments that they do on their skin on a monthly basis, and how that we would evaluate the ABCDE on lesions. We also talked about one of the drugs that's used for these skin cancers, which is the 5-FU, and that it can take several weeks for that to work. One good thing about it is that it's going to look worse before it gets better, but there's minimal scarring as a result of it, and it usually does very well. There is going to be some redness around the surrounding skin, though, so that's to be expected. And it may look painful, it may be red, it may be a little painful even, as a result of that inflammation. Okay, let's see what else we talked about. We talked a lot about your malignant melanoma, just what that looks like. And then we went on into the skin infections, and we talked about the bacterial skin infections, like the folliculitis. Y'all know that has to do with the hair follicles, okay? And one of the things that you need to remember about that is that there can be a secondary infection, you know, as a result of maybe scratching where people itch. So that can cause an infection, which could lead to hair loss if it's in the hair, okay? Because we're talking follicles here of hair. We talked about things like the cellulitis and the warm compresses and things like that. We talked about the MRSA and how people shouldn't share personal items. We always have to do really good hand washing, but we also talked about the medication that's given for that, which was vancomycin. We talked about the importance of observing the IV site and all, because it can cause thrombophlebitis. And as a result of that, these folks can have some very tender area around the site. It can get infected, and that can cause more of a problem for them. We talked about impetigo. Have we talked about that? We did, right? Okay, I just want to catch us up on the impetigo, talking about how that's contagious, right? Mm-hmm. Didn't we talk about that? Okay. And you want to make sure that there's good hand washing, you know, as it relates to that. Now, I still can't say the name of the drug that you mentioned, the Bactobane. I mean, you do it to me. Bactobane. What is it?
Vitiated. Nupericin.
How do you say it?
Nupericin.
Nupericin.
Will you spell it for me, please? I like to spell it in my mind.
Isn't it
Then I can,
MUPIROCIN.
Nupericin.
okay, that kind of gets there a little bit. Okay. But anyway, I think, really good hand washing. Okay, like that. Okay. Now, as far as, we talked about infection before we left. We talked about signs and symptoms of infection. What you might see as it relates to the actual wound infection or whatever infection you got. Okay, we talked about what was basically the three things that we think about with infection.
Pain, drainage, size.
That's right, pain, drainage, size. Okay, now, let's take that just a step further. I think that's where we left off. I just wanted to make one more comment about that, is that how do you know if it's healing? That's a sign of an infection. The pain, the drainage, okay, and the size increasing. Smaller size, that's right. So if a wound is healing or something's getting better, then the size is going to decrease and they may not have any drainage anymore, right? That might be one of the things. And it may start granulating. Okay, just like with that 5FU that you use. It's going to slough off all of that and leave good healthy skin at the end. All right, now we're going to be talking about these viral skin infections. All right, who has the herpes simplex? Well, this is the introduction slide. Who has that?
We have the first one. So I'm not gonna go through each one of those. They're all
No,
gonna come up.
that's right.
We have the herpes simplex.
You have that one?
Herpes simplex 1 is around the mouth and lips, and herpes simplex 2 is going to be found below the waist.
There you go.
Type 1 can cause type 2. The sores around the mouth are usually painful vesicles with a red base to them, and it spreads through contact.
The virus remains dormant in the system, is triggered by stressors such as fatigue, sunburn, and trauma. The attack lasts from 3 to 10 days, and they're contagious for 3 to 5. It's worse with immunosuppressed individuals and with age, and again, it's spread through contact. Yes.
All right. What about you two? You talking about contact?
Yeah, sexual contact.
Sexual contact. Okay. All righty. So do y'all understand the difference in the two? You do? Okay. All right. One of the things about, herpes simplex virus, especially if you've got a cold sore or fever blister, a lot of times you'll have a little burning or tingling around your mouth about 24 hours before you see the blister. Okay? But yeah, you've got the upper and the lower. Okay? All right. That's some example. And I won't leave that there too long. But that's pretty impressive. Okay, moving right along. Herpes zoster, who has that one?
So herpes zoster or shingles is reactivation of the varicella zoster in patients who have previously had chicken pox. It is a painful rash of grouped red blisters that can lead to crusting. It has a dermatomal distribution, which means the area of the skin is supplied by nerve endings. That's usually found around the trunk or the chest area. Who is at risk? Elderly, immunosuppressed patients who have not had chickenpox or been vaccinated. Also, pregnant ladies, be mindful of that. It is contagious, especially if the rash is crusting. You want to put them on isolation or contact precautions. And prevention is the shingles vaccine. treatment is a cyclogel.
Okay. All right. Okay, now this has the dermatomes, right? You had that picture, right? Or somebody had that picture? Okay, kind of shows you where those nerve paths go, all right? Who's taking care of somebody with shingles? Okay, anybody had shingles in here? It wasn't fun, was it? No, I had some shingles one time. I remember I was working home health at the time, and I was driving, and I kept having this sharp pain hit me in my lower back, and it just kept hitting me, a sharp pain, and I didn't have anything there, nothing. And I kept saying, "No, you know what? There's got to be a reason for this." And so it just kept on, and I guess it was probably about a month or so went by, and I still would have those sharp pains periodically. And then all of a sudden, I had this rash break out, okay? And I put some cortisone, different stuff on it. So I ended up going to the doctor for just a regular checkup or whatever, and I mentioned that. And he looked at my back and said, "Well, you've had shingles." I said, "Okay. Well, it makes sense to me. So let me tell y'all what the #1 priority is for shingles. Can y'all imagine what it is? Pain management. Pain management, because that's nerves and that hurts. Okay? So think pain management whenever you think about this shingles or herpes zoster. Okay?
Does just the antiviral help with the pain, or do you have to take?
No, you may need to have some pain meds.
Okay.
It just depends. It just depends. Hopefully that will help with you, but sometimes you have to have some analgesics. You know, sometimes you might have to have antipyretics, who knows? But then cool compresses, they say, helps as well. But yeah, you never know. All right, but think pain management, guys, when you think about that. And they say they're the most contagious, though. You know, like if you have the blisters and they have the fluid in those blisters, or weeping contact. Okay, moving right along. HPV. Who's got HPV? Anybody? Okay, paying attention. Who has that slide? Did anybody get that slide? Did somebody leave that had that slide? Okay, all righty. Well, what do y'all think that is? HPV, what is that? The human what? Papillomavirus? Okay. All right, why do we give an injection for that, right? To who? Who did they give that to sometimes? Teenagers, teenage girls usually, right? And what is the, they giving it boys now too? Okay, great. Okay. So, what was the original purpose of it?
To prevent you from getting.
Yeah, why would we give it? Right, to prevent cervical cancer. Okay. And there was kind of, they gave it up to the age of, it was 26 at one point.
Yeah, from like
There
11
again.
to there,
Pardon me?
like from 11 to 26, I think, or something.
Yeah, but they may have changed that too, so I don't know. Maybe I need to keep up better with that. But, anyway, that's just something that's mentioned here because they can have what? Genital warts as a result of this. Okay, so that's a skin integrity issue there. Okay? All right. Fungal infections. Who's got that? Now, come on now. Let everybody move. Who's got the, nobody back there? You do?
That's three.
Good. Thank God. Everybody can leave. Okay, wait. Y'all want to talk about it?
Where do you want us to start?
Well, I'll go right there.
Okay. All right. I don't know how to say.
Kenya?
Those words.
Oh.
Tinea is fine. Capitis.
Capitus.
traumatic.
They call it the ringworm of the scalp. It's a fungal infection of the scalp and hair shafts. Symptoms include itchy, scaly, bald patches on the head. It's most common in toddler and school-age children, and it's very contagious.
Okay.
Treatment is the oral GRISEOFULDIN. And you can also use the medicated shampoo. The topical treatment's not, so they definitely need the oral antibiotics.
Okay.
The second one. It's a ringworm of the dividing, develops on the top layer of the skin. Superficial fungal infection of arms and legs, however, can occur on any part of the body. It also includes document signs and symptoms. Edge of rash appears elevated, scaly to touch, dry and flaky. Hair loss in the area of lesion, circular rash, and it causes human to human contact, animal to human contact, object to human, and soil to human.
Okay.
Risk factors: live in warm climate, close contact with infected person or animals, sharing clothing, bedding, towels with fungal infection, skin to skin contact, such as wrestling, contact sport or something like that, and weaken immune system. Prevention: keep clean, stay cool and dry, avoid infected animals, and don't share personal belongings.
There you go. I think you summed it up pretty good right there. Anybody ever had a ringworm as such?
I
Okay.
had one, when we were little, was a dog that we wasn't supposed to be playing with. I got it. Our parents didn't allow us to have dogs, so we used to sneak down the street and play with the neighbors.
Okay.
And we used to say, why? I had it on my like arm and hand, and I got rid of it easily. But my brother had it, and it didn't go away so easily. He ended up going to a dermatologist,
Yeah.
and they said he had it systemically, so it was really bad.
Okay.
I had about 30 of them.
You had 30.
It was about 30 of them. I went off to college, and when I was like shower, I had ringworms all over my body.
Wow. Did you have to bathe in some stuff or what?
They gave me
Get
some
rid of
medicine
it.
about that.
Okay. Okay. All right, guys, this is just one of those infections that, you know, people can get. And, sometimes you can run, but you can't hide, huh? You can play with certain animals that you don't really know about, okay? But then again, it talks about putting on somebody else's hat. You know what I mean? Contaminated hats at school, you know, when you're kids and stuff, and you don't think about that kind of stuff. You know what I think about in the airplanes? They don't clean those planes good enough, I'm telling y'all. And every time I sit back in one of them things, I think about maybe who was sitting there ahead of me. I'm just saying. Okay, moving right along. All right, who has this one? Who has it? Can you do it? Okay.
There were a couple more on that last slide.
Oh, I'm sorry. I thought y'all covered them all.
The tinea pedis.
Oh, I thought she mentioned the jock itch too, so. Anyway, go ahead.
Tinea pedis, also called athlete's foot, infection of the soles of the feet and interdigital spaces called fighting vision. Commonly occurs in people with very sweaty feet, combined with tight-fitting shoes. Treatment can be treated with over-the-counter antifungal meds. Signs and symptoms: scaly rash that causes itching, stinging, burning. It is contagious, can be spread via contaminated floors, towels, and food.
Yeah. We see that a lot with athletes, right? Because they have those showers and they don't wear shoes, what have you. Okay.
Tinea pedis, that's jock itch, fungal infection of the genitals, inner thighs, and buttocks. It's kind of the same as the
Okay? All right, so the main thing here is moisture, right? On a lot of this. More moist environment that allows for this to be transmitted. Okay, now, the next one is the candidiasis. Y'all have that one too? Okay, go ahead.
An infection of the skin and nails caused by the Candida fungus.
Okay,
Red rash, usually between the fingers and toes, around the fingernails and toenails, and the blood, as you can see here, it can pretty much hit any crevice. And treatments include antifungal medication and skin drops.
okay. All right, so the take home from this one here is this is showing the skin folds underneath the breast, right? That's what that looks like to me. Okay, so what we're going to think about, what is the main thing that we're going to do for these people who have this yeast?
Keep them dry.
That's right. The main thing you're going to think about is keeping those folds clean and dry. Okay? That's the main thing as far as nursing that we do. Of course, they can have it other places, you know, where there's closed areas and it allows moisture. You know, tell me about the oral. Did we talk about that? Did you talk about the oral? Just this one? Okay, let's talk about the oral for just a second. It says mucous membrane, so we don't want to forget to mention that. So what do y'all remember about,
Isn't it thrush?
yes, like thrush, that's right. What color is that?
White.
That white, creamy cottage cheese looking
Ugh.
stuff in the mouth, right? Okay. And what's good for that? What's good to treat that with? Nystatin. But if it was just somebody that you were caring for, and you know, nurse can give the nystatin, but the nurse assistant can't. Okay. But what could the nurse assistant maybe?
Oral care?
Yeah. And what would they use for that with that? Do y'all remember anything about that? Warm saline. You know, warm saline is good to rinse the mouth on people who have thrush or the candidiasis in their mouth. Okay? So that's a little patient education there. Parasitic infections. All right, who has the, let's just go on to the particulars. Who has that? Yeah, go ahead.
I have the pediculosis capitis is head lice, the corporus is body lice, and the pubis is pubic or crab lice. The capitis is common in longer hair, causes itchy scalp, and secondary infections may occur from the itching and constant scratching of the scalp. The corporus is lice that live and lay eggs in the seams of clothing. Their visible sign of infestation may be on the trunk, abdomen, and extremity. The pubis is intense itching of vulvar and perirectal area. They're contracted from infested bed linings or during sexual intercourse. Treatment, you're going to do peeling of the parasites with topical sprays, creams, and shampoos. Permethrin is usually used. Oral ivermectin may also be prescribed. Pillows, chairs, mattresses, hairbrushes, combs, clothing, and hats should be disinfected. You want to wash them in hot water or dry clean. The use of fine-tooth combs may help remove the nits from the hair, and you want to treat social contacts and other family members.
Okay. And I think most of us are somewhat familiar with lice, right? And we think about, you know, yeah, it can be in different areas of the body, all right? Like kids, for instance, though, that come home with it, you know, from school, has to be treated, right? And so that doesn't really say anything about their environment, but they could get that from someone at school, okay? But nonetheless, it has to be treated to get rid of it. She made some valid points about the permethrin and what we call lindane, I believe, is another one, and there's another topical now. What is it? Did you see that one? The topical.
Ivermectin.
What is it?
Ivermectin. is what
Okay.
they listed in the book.
Okay. And,
But that's oral.
well, there's a topical one that's let's see what it's Malacron or something like that. It's a topical. But don't worry about it. I'm just making mention of some of them. But the main thing is that it has to be treated, and you mentioned the fact that they have to wash the clothes in really hot water, you know, and treat anybody in the family so it doesn't continue to be passed around. These little things don't hop from one person to the other. Have y'all actually seen one?
Yes.
You can actually see what they look like.
You can
Yeah.
see the nets too.
Yeah, the knits too, you're right. Yeah.
When we did our pull-outs last semester, I had a kid at the school that had it.
Did you? Did y'all, is that what y'all went to do, was to look in their heads, or it was just something that?
We were being
We
a
did-
school nurse.
Yeah, we had pull-outs with school nurses
Oh.
and coastal family.
Okay.
And one of the kids at mine had it.
Well,
And then the other thing is, oftentimes, if you have to have someone watch them, we would, I know it sounds really bad, but they would get the African-American teacher to be with them because darker colored hair and stuff, they're more drawn to blondes. You'll see lights more predominantly in blondes.
That's not, it's because we have oil in our hair.
Cause you got all.
But also people with dark hair, it's less likely for them to get also.
It's less likely to what?
For people with dark colored hair and, you know, oily stuff, for them not to go near them.
Okay. All right, y'all teach me something all the time. Okay, let's go on to the scabies, guys. Wait a minute, did I just do that one? Sorry. All right, yeah, we gotta move on, we spending a lot of time, that's okay. Go ahead.
They're usually self-diagnosed by intense itching. with
Y'all
bumps-
listen now, she's talking about the scabies here.
With bumps and redness of the skin where mites burrow. The itching becomes worse at night. It's transmitted through contact with an infected person or bedding. It can be carried by pets and found among homeless as well as institutionalized older patients. Examine the skin between the fingers, palms, and wrists. It's treated with anti-parasite cream, which is the same that's for lice.
Mhm. Okay. All right.
Alright, and then the bed bugs, pretty much self-explanatory. They hitchhike from like hotel rooms and stuff like that, where you go to the infested area and bring it home. Treatment is antihistamines or creams, just depends on how you're reacting to their saliva when they bite. Getting rid of them can be frustrating, so pretty much the only way to completely get rid of them is pest control professionals. Heat is pretty much the only thing that kills them in their eggs.
Okay, so they have to wash their linens and stuff really in hot water too, huh?
Yes.
Okay.
Wash clothes and personal items in hot water.
Okay. Let's move on and show you the pictures there. See the difference in the scabies and the bed bugs? And you can see what they look like down there as well. One of the things I will say, you mentioned about the poor hygiene, the crowded conditions, and even pets can carry it, okay, as far as that's concerned. What I remember about the scabies in particular, and I'll just make mention to y'all that you might want to remember, is that we use a magnifying glass and a pen light to be able to look at that scabies to see if you can see that burrow. Okay? Another thing that's used, the health department use this. I worked for the health department for 5 years. And, you know, you get a lot of these different things that come in and out. And what they would do with those scabies is take, like, you can get them like here in the fingers, you know, the hand. They would take like a Sharpie or a black marker and mark through that, and you'd see those burrs. That's how they could diagnose it as scabies, because they'd see those, you know, it would sink down into those burrs.
Just something to think about. We went on vacation in, I think it was Austin, Texas, and we went to the movie theater and they told us, we pre-purchased the tickets and we got there, they said we couldn't see the movie, so we were like, oh, why not? They had, like a group home has on there during the day for a movie and they had scabies, so they weren't letting anybody in the movie theater because they had to clean it. So now every time I go to the movies, I'm like all freaked out and I take my clothes off as soon as I get home. But I live in Louisiana and the Victoria's Secrets in Mandeville have a friend that works there and they were like getting rid of their bras and they had to do all kind of inventory because someone had scabies and try on inventory. So now I'm like,
That sure makes you think, don't it?
Yep. And then the bed bugs were bad up north. The bed bugs were real bad up north.
Okay, now. All right. Y'all, I'm just telling y'all that it's like I say with the airplane. You know, I don't know what's in my head when I get out of there, and you just don't know. You don't really know. You know, you can run, but you can't hide, you know, from all this stuff. But you just have to be made aware of it. So anyway, I want your take home on this one, as far as your scabies, to be that you would use a magnifying glass, okay, and a pen light to be able to see those burrs. And that's how they sort of make a final diagnosis of that. And then there again, like with the bed bugs, you got to treat them, but yet you gotta get rid of stuff. You know what I'm saying? Or get it really, really hot water.
Bleach on
Pardon?
that. Bleach.
Think bleach will help?
Oh, yeah.
Or hot water? Bleach helps everything, huh? All right, what about psoriasis? Who's gonna talk to us about psoriasis?
Right here.
Okay, go ahead.
All right. It's a lifelong disorder with exacerbations and remissions. It appears to be autoimmune reaction from overstimulation of the immune cells. Aggravating factors are strep, yeast, respiratory infections, stress, drugs, and obesity. The lesions are thick and scaly. They have scaly patches with sharply defined borders, and debilitating arthritis may occur.
Okay.
Okay, and then I have some of the treatments. The steroids are anti-inflammatory. You put those on, they suppress cell division. Topical steroid depends on the potency and the severity of it. You also want to make sure you apply whatever you're applying exactly to the wound, because if you don't want to get it on any other part of your skin, because that might damage healthy skin and you don't want that. And so tar preparations applied to the skin, solutions, ointments, gels, lotions, and shampoos. They're messy and they stink. That says it in the book. Topical therapy relieves chronic psoriasis. I said the 2-hour thing. Ultraviolet light, that's what kind of works like the sun and kind of dries out the sores. Your skin pigmentation determines the amount of exposure, and you want to teach the patient that it's okay to have these things and you can touch them.
Yeah.
You don't have to wear gloves.
That's right. Okay, let me tell y'all a few little things. In addition to that, what is one of the triggers? What is stress? Yes, y'all remember that. Stress is one of the triggers. Infection can be a trigger, okay? Different types of stress. Candida, can be one. Strep can be one. But stress is the main thing for these folks that can trigger, you know, an outbreak of psoriasis. Hormonal changes, things like that can affect it. Like when they start with puberty or maybe even go through menopause, that can be an issue for them. Another thing about it is, we said earlier, it's not contagious, right? It's okay to touch these folks. But one of the things is that sunlight can help shrink those lesions, okay? So that's one of the things that we think about, and of course we do have topical creams and things that we put on it. Y'all remember this too, is that lotions and emollients or, you know, that type thing is better for psoriasis. Lotions and emollients are better for psoriasis, but it needs to be in thin layers. Okay? So, you don't want to do a lot of drying agents on these folks, in other words. You don't want to, you want something that's more of a lotion type thing rather than a drying agent. So they need to avoid things like hot water. They need to avoid any kind of soap that might dry them out too much. So avoid those kinds of things, anything that would dry them out too much. And they should pat dry rather than rub, okay? So those are just little tidbits that you might want to think about. Stress being the number one problem. Okay, the last thing on here, and then we'll be done with this, is basically what is acne. Okay, anybody here ever had acne? Okay, so, I mean, it's usually, you know, it happens in early adulthood or teenagers, you know, we see a lot when those hormones start to change. And it can be, that bacterium is called, say that one for me. What's your name? Say that one for me. The bacteria. The that one.
Go ahead, Alan.
Come on, somebody say it. Y'all.
Proprion bacterium acnes.
There you go.
Proprion.
All right. All right, so basically what these clinical features are is you got this plugging up of these little sores that causes papules, okay? So everybody knows what acne looks like, okay? And then there's medications that they give for it. Y'all have heard of all these medications, the benzoyl peroxide, salicylic acid, retinoids. This one here, though, this was the one that I want to point out, the isotretinoin. What's that? What is the trade name for that one, guys? What is it? If y'all can say it, I can remember. What was it? Oh, man, is it
Tretinoin by itself.
Accutane or something like that? That sounds right, Accutane? Okay, I think it's what that is. And let me tell y'all though, the key on this one, the reason I mentioned this one, is it can cause birth defects. And y'all just need to know it's teratogenic, which means that it can cause birth defects. And that's really all I want to say about that. You know, y'all understand about self-image and stuff as it relates to these young folks and even older folks having a lot of acne with scarring. So there is a body image that relates to that as well. So we have to make sure that we're supportive of that. Okay, guys, y'all been very patient with that. I'm sorry it took us longer than I intended, but what I'd like to do, I need to pick up my little cards from you. And that's just some little things that y'all can go on your PowerPoint